Good evening, dear colleagues. I have the pleasure and the honor to moderate this webinar organized by Eurolebanese Medical Society about COVID-19 and the heart, a complicated love affair. On the behalf of the organizing committee and the scientific committee of ELMS, I would like to welcome you to this webinar tonight. I am Dr. Antoine CHEDID, a cardiologist specialized in vascular medicine and hypertension. I'm working in the Excellence Center of Hypertension at the European Georges Pompidou Hospital in Paris and in a private clinic also. I have worked in reanimation for many years, and recently I have cared for patients with COVID-19, where all reanimations in France were closed and transferred to receive COVID-19 severe patients. If we come back to our topic of this evening, to the complicated love affair between COVID and the heart, we would see that few of us could have imagined that hypertension and its treatment with inhibitors of renin-angiotensin-aldosterone system would become a hot topic during the global COVID-19 pandemic. Two factors have contributed to this. First, the observation that hypertension was one of the most common comorbidities associated with severe COVID-19 and who have been admitted to intensive care, and it was also associated with death. The second, that like the severe acute respiratory coronavirus, SARS-CoV-2 infects cells via specific binding to angiotensin-converting enzyme 2, to ACE2, which is ubiquitously expressed in lungs, in the heart, in the brain, and in the endothelial cells, endothelial vascular cells. These factors have fueled speculation that the use of expression of ACE2 in the respiratory tract, thereby increasing the risk of both becoming infected and developing severe life-threatening complication due to COVID-19. Anxiety among patients and physicians have been profound because ACE inhibitors and angiotensin receptor blockers are the foundation of drug treatment for hypertension, heart disease, and chronic kidney disease, and are among the most widely prescribed drugs globally. To speak about this topic, I would like to welcome Dr. Hussein ISMAIL. He is Associate Professor of Medicine, the President of Medical Committee, and the Director of Vascular Medicine Program at the American University Hospital of Beirut. Thank you, Dr. Ismail, for being with us tonight. We are glad to listen to your presentation. The floor is yours.
ميرسي دكتور شديد على البرزنتيشن، وبحب اتشكر الاورجنايزرز على تعبهم لحتى يعملوا هالاكتيفيتي بهالوقت. بعرف انه كتار منا مرقين ب very stressful conditions بلبنان. ان شاء الله انه اقدر امن شيء هيك يكون يوصل رسالة وبسيط بذات الوقت. So I was asked to present an update on the hypertension and COVID-19 story and a briefing for the non-imaging specialists about what to expect when you're considering sending patients for with COVID for imaging, for cardiac imaging tests. So COVID-19 has definitely proven to be a world-modifying agent in terms of we're qualifying to a time worth the description below. And as a disclaimer, I'm not a communist. However, I thought that this was very worthy of the time. There are decades where nothing happens, and there are weeks when decades happen. And obviously, the amount of stress and the changes that are happening globally during this year, maybe we have not witnessed similar things in decades. So why we cardiologists got interested in COVID? Well, you could say that primarily it's because overall humanity got affected. Two, the disruptive nature of the infection affected our work indirectly. And then number three, it's the disruptive nature affected us directly. And how so? Well, one, it involved the ACE2 receptor, which is closely related to our field, as we will be explaining later on. The complications of the disease involve the whole cardiovascular system at many levels, and I'm going to be showing that through a very simple case towards the end. Something that we do very frequently, which is pre-operative assessment processes, had to be changed and adapted to the disease. Getting patients into the cardiac cath lab processes have to change also to ensure safety of the healthcare providers, physicians, nurses, and technicians. And the data suggested that patients with cardiovascular disease had higher mortality, and therefore it was a major concern to our patients. And we had to work with them together on a very fast pace in order to determine what's best for them and how to manage their conditions during these difficult times. So moving forward to the gist of today's presentation, which is the relationship or an update about what's happening with hypertension and COVID-19. So the story began basically from the spike of the SARS-CoV virus, which is shown over here in red. And it turned out to be, a spike that binds to the ACE2 enzyme. Now, this enzyme is not only present in blood, but it's also present, it functions as a receptor and is present on many different types of cells, including the epithelial cells in the lungs and other cells in the heart, in the vessels. And we were going to see that it's actually present in many different organs as well. So once the SARS-CoV uses the S protein and binds to the ACE2 receptor, it's actually internalized, and this is when the RNA viral replication starts through joining the endoplasmic reticulum, internalization to the endoplasmic reticulum, and then formation of new viruses and more infection. So when the first data started appearing from China, and then later on from the other parts of the world, it became obvious that the SARS-CoV infection is challenging the heart in many different ways. So, and as we are learning, you can easily say that the pathways, although may appear to be complex over here in the slide, are actually going to become much more complex because of bidirectional interactions between different situations. So the simplest thing to imagine would have been that the SARS-CoV actually infects endothelial cells and therefore causes a type of vasculitis. And that's something that we have seen. It affects the pericytes. It actually only stresses the heart in terms of increasing the stress on the overall system, and therefore leads to plaque erosion, and can either lead to microvessel or macrovessel thrombotic formation, or even a Takotsubo-like picture. And then, came the other part, which is the identification of myocarditis as a complication of SARS-CoV. And here in myocarditis, we actually, the scientists noticed that there are two types of myocarditis. There is a myocarditis that is related to a direct infection of the heart, and then there is a myocarditis which is related to just a lymphocytic infiltration with no actual viral replication inside the myocardial cells noticed. So furthermore, more cases started showing up, showing myocardial dysfunction, also arrhythmias. So you can easily say that SARS unleashed basically a full attack on the heart. And when we talk about the full attack on the heart, we were talking about on the conduction system leading to arrhythmias, an attack on the myocardial system, cardiac dysfunction, and an attack on the vessels also. So, the first set of data started appearing from or suggesting an interaction or a threat to patients with hypertension and under being treated with the RAS blockade system, such as the ACE2 and the ACE inhibitors or the ARBs. Initially, it was thought to be more of a hypothetical question. And then what came and mixed up the picture a little bit was that the presence of hypertension was clearly shown in numerous studies to predispose patients to being becoming more severely ill, and also turned out to be a risk factor for death. So, and this is what you can see over here, that the prevalence of pre-existing hypertension was higher among those who developed a severe illness in 4% compared to 1.1%, with a hazard ratio of 2.1 for being hypertensive compared to not being hypertensive. Now, and the speculations, started rising, suggesting that the ACE2 receptors myocardial cells for infection. Now, luckily, this was not reproduced in tissue, and new data is clearly showing that patients with hypertension are, yes, 2.12-fold at higher risk of death from COVID. However, among hypertensive patients, those off treatment, 0.17-fold increased risk of dying compared to on treatment, and that's regardless of what treatment. And then, in a nice meta-analysis that was recently released, where they combined patients from the Hussein study plus 2,300 patients from meta-analysis, showed the lower risk of death among those treated with the ACE inhibitors or ARB compared to other antihypertensive. However, all of these results, have to be taken with caution, simply because these are all retrospective studies, and there is always a room for error when we're talking about retrospective studies. However, it seems to be a fact that what we were very concerned about earlier on at the beginning of the epidemic, as we are learning more and more, it seems to be that that the problem is in having hypertension, but not in actually whether we treat with ACE inhibitors or the ARBs. Now, newer data just came out recently, around a few weeks ago, showing that the circulating plasma concentration of the ACE2 enzyme in men and women with heart failure, and how, studying how this level is correlated with the angiotensin aldosterone inhibitors. And this is very important. What they did was they took two groups. The first was 1485, one index cohort and validation cohort, split males and females, as you will notice over in the first paragraph in the methods and results. And then they studied what were the predictors of elevated concentrations of A2, and it was found of ACE2, and they found that the most important and strongest predictor of elevated ACE2 levels was actually male gender. Now, when they studied in detail, the use of ACE inhibitors, the use of ARB, they did not find an interaction. However, when they looked at the use of the mineralocorticoid receptor antagonists, they found a signal showing as the MRA being independent predictor of higher plasma ACE2 concentrations. Now, however, a word of caution that this was only found in the validated cohort, not in the index cohort, and therefore, so far we can say that with certainty that ACE2 and ARB use is not associated with higher plasma ACE2 level concentrations. It's more gender that is associated. And as for the MRA use, there is a signal that can potentially show an association. However, there is no true evidence for that at this level. Now, everybody then now started wondering, where is this association coming from? Why is it that males are, to start with, at increased risk of severe illness and are at increased risk of death compared to females, as is showing in many of the risk assessment models? And on the other hand, what is the relationship of the elevated ACE2 levels in males, circulating ACE2 levels in males compared to female? And there seems to be some kind of suggestion that since the testes are a site of ACE2 production, then probably it's actually not hormonal, more or so. It's the actual site of the production of the hormone happens to be a shared site of production of ACE2, meaning over here the testes could be the culprit organ for causing this increased mortality and increased susceptibility for severe illness in males. So, to conclude in this, and just to give you this update in brief, hypertensive patients should remain extremely cautious, adhering to general recommendations to prevent infection to start with, because they are at increased risk of contracting the disease and developing severe illness and death, especially if they are males. However, when it comes to the choice of therapy, there is no evidence whatsoever to incriminate at this stage ACE inhibitors on ARBs. To the contrary, being on ACE inhibitors on ARBs actually is showing signals of benefit in terms of control of blood pressure and also a lower risk of complications compared to the other antihypertensives. There are no recommendations whatsoever regarding MRA mineralocorticoid receptor antagonists, as results till now seem to be inconsistent, and therefore there is no final judgment on that. So with this, I would like to thank you and hope that you all stay safe, and hopefully we get to meet again later and further address any updates. Thank you very much, and I look forward to hearing your questions.
Thank you, Dr. Ismail, for your excellent presentation. We will do discussions later on, but before, let me introduce another speaker, because the complicated love affair continue between COVID-19 and the heart. And now we will deal with acute coronary syndrome. I have the pleasure to introduce you Dr. Claude Saman. She was graduated in the University Catholique de Louvain in Belgium. She is the first woman who practiced interventional cardiology in the Middle East. She was practicing this specialty from 1989, and we are so proud that Dr. Saman is the first woman to be the president of the Lebanese Society of Cardiology. She's actually working in Maritime Hospital in Byblos, and she was one of the cardiologists that developed interventional cardiology in all Lebanon out of Beirut. Dr. Saman, the floor is yours. We are glad to hear your presentation.
Merci, Dr. CHEDID, pour cette présentation. We will talk about COVID-19 and ischemic heart disease. This presentation is based on ESC guidance for the diagnosis and management of cardiovascular disease during this pandemic. SARS-CoV-2 not only causes viral pneumonia, but has major implication for the cardiovascular system. Patients with cardiovascular risk factors have been identified as particularly vulnerable populations with increased morbidity and mortality when suffering from COVID-19. Moreover, a considerable proportion of patients may develop cardiac injury in this context and increase the risk of in-hospital mortality, like ACS, VTE, myocarditis, heart failure, or arrhythmia. Access to emergency treatment, including reperfusion therapy, may be affected depending on the severity of the epidemic at a local level. This is further aggraved by increasing concerns of delay presentation of CV emergencies, as patients are afraid to seek medical attention during this pandemic. A study including 5,700 patients in USA reported the prevalence of cardiovascular disease factor. We have more than 56% hypertension, around 11% coronary artery disease, and around 7% congestive heart failure were the most common comorbidities in this population. In another study, in 416 patients of whom 57 died, cardiac injury was a common finding, around 20%. And in the patients who died, 10.6% had CAD. Moreover, in multivariable adjusted models, cardiac injury was significantly and independently associated with mortality. Similarly, in another study, elevated troponin T levels due to cardiac injury was also associated with significantly higher mortality. On the other hand, COVID-19 infection may also be linked with an elevated long-term cardiovascular risk. This is because follow-up studies of the SARS epidemic demonstrated that patients with a history of SARS coronavirus infection often had hyperlipidemia, cardiovascular system abnormalities, or glucose metabolism disorder. Naturally, no long-term effect of COVID-19 infection are known yet, but these effects of a SARS coronavirus infection justify surveillance of recovered COVID-19 infection patients. If we talk physiopathology, cytokine release storm originating from imbalance of T-cell activation with dysregulated release of interleukin-6, interleukin-17, and other cytokines may contribute to cardiovascular disease in COVID-19. Interleukin-6 targeting is being tested therapeutically. Immune system activation along with immune metabolism alterations may result in plaque instability, contributing to develop ACS. In STEMI, the COVID-19 pandemic should not compromise a timely reperfusion of this patient. In line with current guidelines, reperfusion therapy remains indicated in patients with symptoms of ischemia of less than 12 hours duration and persistent ST segment elevation in at least 2 contiguous EKG leads. If the patient in STEMI arrived at hospital without without cath lab service, we should do fibrinolysis. If the transfer for primary PCI is possible at hospital with cath lab service 24/7 service available, primary PCI should be applied. In STEMI, because there is no time to wait for nasopharyngeal swab result, the procedure should be performed in a dedicated COVID-19 cath lab if available. In regions with high rates of community transmission, it is reasonable to regard all patients as possible SARS-CoV-2 positive and personnel protected accordingly. The safety of personnel should be ensured. To that purpose, and in the absence of previous SARS-CoV-2 testing, all STEMI patients should be managed as if they are CoV positive. Personnel should be well versed in proper techniques for donning and removing PPE, including eye protection. Cath lab directors should ensure adequate availability, replacement, and training in the use of this equipment. All patients entering the cath lab should wear a surgical mask. Now, if the patient is with non-ST, If they're at very high risk, immediate invasive strategy should be applied. If they're at high risk, early invasive after test results can be proposed, and the target is less than 24 hours. For intermediate and low risk, non-invasive testing should be applied. For managing of chronic coronary syndrome, continuation of medication in this category is recommended. Follow-up via telehealth is recommended also. Revasc must be postponed in low to intermediate risk patients. Revasc of high risk patient may be considered. Postponing of non-invasive testing patients should be considered also. CT angio should be preferred of non-invasive functional testing. Screening for SARS infection should be considered before cardiac surgery with nasopharyngeal swab and CT scan. PCI may be considered over CABG in selected patients, and identification of COVID-19 free hospital may be considered as hub for cardiac surgery. Finally, this slide resumes the strategical categorization of invasive cardiac procedure during the COVID-19 pandemic in ischemic heart disease. The treatment should be applied in emergency for STEMI, non-STEMI ACS in very high-risk patient, and in cardiogenic shock. We can perform the treatment within day in non-ST ACS in intermediate risk patient, in unstable angina for PCI for left main, last remaining vessel PCI, decompensated ischemic heart failure, angina class 4, and CABG in patient with non-ST unsuitable for PCI. The treatment can perform within 3 months for lower priority, code by code. This is for advanced CAD with angina class 3 or NIHA class 3 symptoms, stage PCI of non-culprit lesion in STEMI, and for proximal LAD. For the elective strategy should be applied for CTO and CCS with angina class 2 or NIHA class 2 symptoms. Thank you for your attention. And I'm so sorry for my very bad accent in English. I'm a really pure Francophone.
Thank you, Dr. Saman, for your interesting presentation about COVID-19 and ischemic heart disease. And now I have the pleasure and the honor to introduce you our third speaker, Dr. Bahjat ASSAF. He's a family medicine and cardiologist in Spain. He's the founder and the president of Hispano-Lebanese Medical Society, vice president of Spanish Traffic Medical Society, and he's the founder of Cardiophone Transtelephonic ECG. Dr. Assaf, the stage is yours. We are glad to hear you.
We're glad to see you and to hear you, all of you. It was a very good presentation. Both Dr. Saman and Dr. ISMAIL. Now, well, I'll tell you about something about traffic medicine in Spain. 25 years ago, Spain was had a lot of traffic accident because we had no good system, medical system, I mean. So they thought in the health ministry and internal ministry to make this as a project health system, because at that time we had, especially in young people, the mortality was in between 18 years and 32 years, was the first cause of death. So this make that to prevent accidentability because of trust on or problem, health problem. So they begin to ask for make a special clinics to examine these drivers, because they made a new rule that it depends on the age you have to renew your license. So in these places must be in these clinics specialty for the drivers. They have to have a psychologist, ophthalmologist, and internal medicine or general medicine. So in these 25 years, we had changed a lot of things. Myself, as a cardiologist, every 4 years, the government changed the law. We present our SEMT society, our ophthalmologist, neurologist, endocrinologist, cardiologist, change every 4 years the rules, because as you know, the medicine, it become more new and can change how can the driver make take of his health. So, for example, in cardiology, the last time people who had arrhythmia or heart infarction disease, they couldn't drive. They took the license from them. But now, no, because of the advance of the medicine, so they have more propriety to drive, and we put in the administration and the health societies the new concepts of cardiology. So this was, for example, the implantable cardiology devices. Now we can use it wireless in cavitarian heart for arrhythmia or block. This made that the divers can again had their license. Well, a lot of question of health like diabetes, glaucoma, uh, all these things now it's new. So the Spanish people now, the administration has a new statistic that the level of accidentability by health is less. This is a new for us, and we are all very happy for the degrees the accidentability. About the cardiophone, this is an invention. I made it in 2001 with the aid of the government, and we present this project. I want to speak about it because I presented in Lebanon to the ex-minister, health minister, and I give the project as free, because our system is a very good for reception by telephone, because it has no, when we decided to make it, we stayed 3 years to make the invention, because the other instruments or equipment had a lot of problem in transmission, especially in the interference. So what we made is to take this interference that can anyone see the ECG by telephone very, very clear, especially in cases in arrhythmia and Wolf, for example, Wolf Parkinson disease. In other way, the other projects, you cannot see it very well, especially when you want to see the delta. And in AF arrhythmias, it wasn't clear. So it was a lot damage for the patient or for the person to see the EKG in bad reception. So our equipment and software and hardware make this very clear in any way, in any by telephone, phone, direct or indirect. So the patient, the doctor can see directly EKG and directly can tip, print it and take it to the, give it to the patient. So I mean, this concept of electro physiology of the heart by a small machine, it can take a place of prevention. Very in 20 years we have detect a lot of heart disease was unknown and uh, send the patient to the hospital urgently, like arrhythmia, heart ischemia, or heart infarction, or another way. I mean, our project, I want to tell you for all our society, ELMS, that I will be ready and free to give this project to this society, to Lebanon, and put it in Lebanon in all villages that's very far from the city, and they have no cardiologist, because this prevent a lot. In 20 years, our experience showed us the valuable and the high prevention of the people, because it's very, in this way it's free. But anyway, it's not expensive to have a machine to send by phone, mobile, or normal telephone to any center, and you can see that this person is a patient, heart patient, heart attack, or any arrhythmia. It helps a lot. It helps general medicine. So I can give you this offer as a present to study it in Lebanon, because I presented to ex health minister that I gave him one simple to see it. He was very happy, but they didn't ask me to put it in Lebanon. I repeat, I don't want business. It's just a present, a gift for Lebanese people. At least we can put it in south, east, west, north, one equipment, and put a center in any hospital to receive this EKG. So this is my offer to my people in Lebanon, and about through our community, ELMS. If we can do it, I will be very happy.
Thank you.
Thank you very much, Dr. Assaf. I see that Dr. Saman is on duty. We appreciate a lot your presence.
Thank you.
Right? So
Thank
you
you
can
very
feel
much.
free if you have an emergency. You don't have to stay with us really.
Okay. Okay.
And Dr. Assaf, so I understand that you were the precursor of the telemedicine. Yes. I understand with your cardio fund that you were the precursor of the telemedicine that was developed very highly recently during the COVID pandemic. In France, it was very important to do consultations with patients staying home. Yes. So you were the precursor of this telemedicine.
So we do. So we did in Spain. especially as you said that the people who are staying at home, especially those who had before the COVID heart disease. And we used to follow them by telemedicine, by this system. So we can, especially those who had arrhythmia and they have AF, but sometimes they translate from AF to flutter. So this was the call, the very rapid call to the send this EKG to the nearest hospital where is the patient is to take him to the hospital. Or you know that a lot of patients after 7 days or 8 days, they may have heart attack and they have it. So this way by telemedicine had a lot in all these patients. Even in another, not in their home, some small clinical in all the country that they have our equipment, they used to stay with us in these COVID-19 days. So it was very, very helpful.
Okay. Donc, question for Dr. Saman. Did you see an increased prevalence of acute coronary syndrome during COVID pandemic? Did you see more patients with acute coronary syndromes comparing to the era before COVID-19 pandemic?
Not really. During the peak of the pandemic, not really. But now we have more than normally. Today we have 3 MI in a small hospital. You know, since 2 weeks now, we have a lot of ACS, not really MI. We have non-STEMI and STEMI, etc., more than usually.
These are patients who did not consult during pandemic because they have fear to go to the hospital.
Yes.
Yeah, okay. There are questions on the chat. Dr. ASSAF Jr. from Great Britain. We are quoting 20 to 25% increased mortality risk for major surgeries to our patients. Have there been similar reports of mortality risk in cardiopaths, in patients with cardiopathies, with heart diseases? Maybe Dr. ISMAIL, you can answer this question.
So, yeah, sure. So the major landmark study that was published in Lancet, and it was a multi-center trial, international multi-center trial, where they just accumulated evidence showing the increased mortality. Now, in that manuscript, the way they analyzed the groups was using a composite score, which is based on the American Society of Anesthesiology scoring system, which looks at comorbidities and assigns an ASA class based on comorbidities. So there was no detailed assessment in terms of which comorbidity, but the higher the number of comorbidities, the more the risk. So I would imagine somebody would have been labeled as, with a high ASA score, meaning that that patient, for example, has heart failure with mitral valve or aortic valve disease, then that patient would have easily been at a higher risk. So, so the mortality rates that are being quoted by Mr. Assaf, I think they're close to reality, although we do not have a large study that actually looks into these specifically. However, they're not far from reality.
Okay. Another question to Dr. Saman.
Yes.
we know that COVID-19, the SARS-CoV-2, increased the risk of thrombosis, of arterial and microvascular thrombosis. Did you see more patients with acute coronary syndromes with coronary artery occlusions? This is the first question. And does it mean that in the treatment of after angioplasty and stent placement, do we have to give them more than aspirin and clopidogrel? Do we have to give them anticoagulant therapy, or the double antiaggregant treatment is sufficient?
By guidance, by ESC guidance, it will be same with or without COVID-19. In our practice, we don't have ACS patient with COVID. In my practice, I don't see that.
Okay.
You know, in our hospital, we don't see that. But my answer is by guidance, by ESC guidance. They say it will be same, the same doses of antiaggregant, same dose of anticoagulant, etc., etc. Because ACS, it's a thrombosis, is a thrombosis.
Nice. So the heart involvement in COVID-19 is important, and not only hypertension and acute coronary syndrome and ischemic heart disease, but there's also myocarditis. I think, Dr. ISMAIL, you told a little bit about that. Did you see in your practice patients with myocarditis, and how did you manage them? How did you treat them? Is there a special treatment, special drugs, or it is as usual for myocarditis due to other etiologies?
So luckily in Lebanon, I think the number of cases altogether was low. So, and the number of cases that were admitted for hospitalization was also relatively low. And and in addition to that, the age distribution pyramid showed the most recent data showed that basically we had, around only 3% of the population were individuals above the age of 75, and there was no real data. Unfortunately, the Ministry of Public Health does not share data, and therefore we cannot tell you exactly what was the prevalence of cardiovascular disease among our patients. However, in my experience, what happened was most of the time we were being consulted for patients who were in the intensive care and to do echocardiography. The majority of these cases turned out to be, having pulmonary hypertension and with a little bit of right ventricular dysfunction. We had only one case of, elevation of troponin with the possibility of myocarditis, but we did not further investigate the case in terms of doing a cardiac MRI or anything of that sort to further elucidate it. Now, what I think is important, and perhaps I can share, this. I'm gonna just share this share screen, looking at this one. So maybe I think you folks can now see it. Can you see it? Just to confirm, can you see the presentation, the slides? If Okay, so I am sharing the screen right now, and if you look at this slide, this is a very interesting case that was published in the European Heart Journal, and it pretty much summarizes everything. This is a regular 43-year-old lady coming in with chest pain, turned out to have SARS-CoV infection by PCR with hypoxia, a little bit of elevation in proBNP, and mild escalation by ECG. And then, ejection fraction was 42% with segmental one motion. But so naturally, they thought of the possibility of, acute coronary syndrome. However, given the age and the, the setting of SARS-CoV, they elected to do a CT coronary as shown over here, and it turned out to be positive. And you know, so they waited a few days, and what happened was that after a few days they did actually, they performed a cardiac MRI, which you can see over here, where they showed that there was tissue edema in the basal segments. You can see them over here, very bright compared to the distal segments. Again, over here, compared to the distal segments, increased brightness, indicating tissue edema. And however, the most surprising thing came actually from the endomyocardial biopsy result. So the endomyocardial biopsy result, what they did was they tested it for replication of virus inside the tissue, okay? And what they found was that there was no viral replication. What, as you can see over here in the stain, they found heavy infiltration by T-cell lymphocytes. So in a way, this was a myocarditis. However, this was a non-infectious, non-SARS-CoV infectious myocarditis. This was more of an inflammatory myocarditis. So yeah, and you know, this is very interesting because what we saw with SARS-CoV and the COVID-19 pandemic is, you know, all ranges of diseases when it comes to the heart, and in this one in particular, we saw, you know, a non-SARS-CoV infected myocarditis. Okay, whereas in others, you know, probably there could have been a SARS-CoV infection because of ACE2 expression on the heart cells. So we personally, I did not see a myocarditis case with SARS-CoV. However, I would reiterate what Dr. Saman said. We are seeing a lot of acute coronary syndrome right now. On daily basis, we are having huge, you know, relatively much higher number of ST elevation myocardial infarctions and non-ST elevation myocardial infarctions. I suspect that everybody was delaying you know, coming into the hospital, and therefore we're getting this surge in the number of acute coronary syndrome.
Personally, I think, Hussein, the problem the problem with the heart effect, COVID heart effect, it will be at long term.
Especially in myocarditis.
Yes.
Especially in myocarditis.
In myocarditis and in risk factor about coronary syndrome.
Due to myocardial fibrosis also?
Due to myocardial inflammation before fibrosis. It's like if we compare to SARS, that's what happened with the SARS.
Okay. So the so yeah, please go ahead. Sorry.
No. I'm listening to you.
Yeah, so I agree with you that we will be seeing, you know, long-term complications. And actually, what is surprising to me so far is that there was a huge emphasis on showing mortality and the acute manifestations of SARS-CoV infection. However, there is not much data so far telling us what's happening with the patients after they recover. Is anybody doing any kind of testing on them in terms of heart function recovery, looking for a SARS-CoV trail, meaning that did they do any MRIs, cardiac MRIs showing scars after recovery? Do we have complete recovery of LV function? These are all questions that are yet to be answered, and I think that we will have a lot of these answers given the fact that we have now nearly 7 million patients, and everybody is so interested in studying these. There is not even a single element in the heart that has not been affected. We know that the electrical conduction system has been affected. We have seen cases of, we have seen reports of cases of heart blocks and arrhythmias. We have seen cases of infectious and non-infectious inflammatory myocarditis. We have seen cases of multi-vessel acute coronary syndrome because of dissections, spontaneous coronary dissections. thrombosis of the coronary vessels without actually having culprit lesions. And we have seen Takotsubo, reverse Takotsubo. So, you know, like it's really has exposed every single aspect of cardiovascular disease that we are familiar with.
Yes, I would like to show you a slide that I took from journal. Mark, if you can please show the hypothesis of cardiac injury in COVID-19. It will resume what you said, Dr. Ismail. Indeed, there's a lot of mechanisms of cardiac injury, and the clinical symptoms are wide, going from hypertension to cardiogenic shock. And this is due to the tropism of SARS-CoV-2 to myocytes and to endothelial vascular cells also. If we go back to hypertension, scientific societies recommended that ACE inhibitors and AT blockers that should not be stopped in patients with COVID-19. Two effects, one protective and one aggressive effect, non-protective effect of ACE inhibitors, of the blocking of angiotensin system. We know also that patients with severe COVID disease have hypertension, that hypertension is a risk factor. Is it a really risk factor for severe COVID disease, or is it an association? Because patients, aging patients, have more high prevalence of hypertension, and we know that aged patients also have a higher risk for mortality in COVID disease. Is it an association that patients, aged patients, there is a direct relationship between hypertension and COVID-19 severity?
So yes, there was a lot of speculations.
Debate.
If it's an association between just age and hypertension, but if you look at the models, at the risk assessment models, hypertension is always turning out to be an independently associated predictor of severe infection and of mortality, independent of age. Now, when you try to analyze that, many people are thought initially that it could be related to the ACE inhibitors and ARBs. However, what is more, and I do not have on me right now the article to show it, but what is turning out to be extremely interesting is actually what we are learning from children. Okay, so right now there is a general consensus in the community that children are less prone to getting infected with the virus, and also they are less infective. So not only do they get infected less, but also even if they get infected, they're mostly asymptomatic, indicating that they have a low viral load, and therefore they spread infection less. And that's evidence that is being used to promote opening of schools. So if you focus on that and you ask yourself, why is it that children are less prone to infection, and even if they get infected, why are they having a lower viral load and transmitting the infection less? The circulating hypothesis right now is because that it is not only age related, it is mostly related to the number of ACE2 receptors. ACE2 receptors children have. Okay.
Absolutely.
So if you think about it, if you measure the ACE2 receptor levels in children compared to adults, then definitely you would hypothesize, or you would find that there is a higher level of ACE2 by age, which was something that was actually demonstrated. It's higher in, it is associated in heart failure patients with age and with male gender. That might explain why you have hypertension over there. Okay, it's related to the ACE2 load. I would say load and burden more than actually hypertension. Now, if you have hypertension and is that related to vascular stiffness, is that related to polyvasculopathy, more of a systemic effect? That's speculations. It may prove to be right, but what we only know right now is that hypertensive patients are at increased risk of infection and severe illness and mortality.
Yes, because hypertensive patients have more metabolic syndrome, have diabetes, obesity, and they are at increased risk of severe COVID infection and increased risk of death. I think we are at half past 8. Dr. Haddad, good evening, is joining us. Dr. Haddad is joining us, but is not listening to us.
I'm listening to you.
Okay, good evening, Dr. Haddad.
Good evening. Thank you very much for this excellent webinar.
Okay.
على YouTube.
I think that we have done, I have asked all questions that were, some friends from Italy congratulated the speakers for their interesting presentation and for the discussion. I think that we may conclude because we had 1 hour, so we are at 1 hour and 5 minutes. We may conclude with Dr. Eli Haddad, who wanted to say something.
Thank you very much دكتور شديد. أنا بنهي اسمحوا لي بالعربي كلمتين. أول شيء بدي أشكركم كلكم على الويبينار الراقي كثير مهم اللي عم ينعمل كل مرة أكثر من مرة بالإلمز. بدي أشكر الدكتور كلود سمان اللي كانت معنا البريزنت إليكت تبع اللبنانيز سوسايتي أوف كارديولوجي، الدكتور بهجت عساف اللي حكينا من سبين، والدكتور حسين اسماعيل كمان اللي من ايوبي ميديكال بريزيدنت اوف ميديكال كوميتي، وبدي اشكر كمان خاصه الدكتور انطوان شديد كارديولوجيست من هوبيتال جورج بومبيدو اللي كان المودريتور، والمودريتور على طول عنده دور كثير مهم بانجاح اخراج الويبينار. احنا التحدي عندنا كل مره نعمل احسن من مره بالويبينار، وان شاء الله نكون على قد المسؤوليه وقد انتم اللي ناطرينه منا. الاسبوع الجاي تحضروا next Wednesday بذات الوقت 7:30 بتوقيت اوروبا، 8:30 بتوقيت بيروت، عن نيورولوجي اند كوفيد. بده يكون معنا البروفيسور حسان حسيني من باريس اللي هو رئيس الشيف دونيتي نوروفاسكولار بكريتاي اونري موندور، اللي هو en même temps رئيس الجمعيه اللبنانيه الفرنسيه الطبيه، الدكتور حنا مطر من بيروت اللي هو عميد كليه التسليك الطبيه بلبنان، نورولوج كمان، الدكتوره ايفانا دبج نورولوج بفرنسا بروان، وبده يكون مودراسيون مع الدكتور إلسا مهنا يلي هي ممبر البيرو ELMS Eurolebanese Medical Society. شكرا للكل عن جديد و stay tuned for next time.